The effect of following clinical practice guidelines on the pain and disability outcomes of patients with low back pain, a critically appraised topic. Clinical scenario. Healthcare clinicians are encouraged to practice according to the best available evidence for the purpose of improving patient outcomes. Clinical practice guidelines are one form of evidence that has been developed to enhance the care that patients receive for particular conditions. Low back pain is a common condition in rehabilitation medicine that places a significant financial burden on the healthcare system. Patients with low back pain often suffer great pain and disability that can last a long time, making effective and efficient care a priority. Several guidelines for the treatment of low back pain have been created. However, there is no consensus on whether following these guidelines will positively reduce the pain and disability experienced by patients. Clinical question. Does adherence to clinical practice guidelines for patients with nonspecific low back pain reduce pain and disability? Summary of key findings. A total of 4 studies of level 3 or higher were found. 4 studies noted an improvement in disability following guidelines of adherent care. 2 studies reported greater reduction in pain with guideline adherent care and 2 did not. Clinical bottom line. Moderate evidence exists to support adherence to clinical practice guidelines to improve pain and disability ratings in patients with nonspecific low back pain. Clinical scenario. Clinical practice guidelines, CPGs, are one form of evidence used to inform clinical practice and have been developed to aid clinicians in providing optimal care to their patients. Clinical practice guidelines are typically produced to address common illnesses, conditions, or diseases, and are based on a critical review and summary of the best available evidence. Experts in medical fields create clinical practice guidelines, and they are subsequently endorsed by professional organizations. One condition that is commonly treated by rehabilitation professionals is low back pain. The majority of the population will suffer from low back pain at some point in life, and costs associated with managing low back pain approach $20 billion each year. Having a formal guideline to drive the management of people with low back pain should assist in generating optimal health outcomes for these individuals. While several clinical practice guidelines have been developed for the treatment and management of patients with low back pain, there remains a lack of evidence regarding the impact that adherence to guidelines has on patient outcomes. Therefore, a review of the literature to identify the impact of adherence to clinical practice guidelines on the outcomes of patients with low back pain and subsequent synthesis of findings is warranted. Focused clinical question. I'm so sorry about my neighbors. Really, I cannot stand them. Yeah, you can understand my pain from listening to this. So sorry about that, everyone. Focused clinical question. Does adherence to clinical practice guidelines for patients with nonspecific low back pain reduce pain and disability? Summary of search. Best evidence appraised and key findings. We searched for studies of level 3 evidence or higher that investigated the effects of adherence to clinical practice guidelines for nonspecific low back pain on pain and disability ratings. 1 observational cohort, 1 randomized controlled trial, and 2 retrospective database reviews were found and reviewed. Reported adherence rates varied across all 4 studies. 4 studies noted a greater improvement in disability scores in patients who received guideline-adherent care. 2 studies reported greater reduction in pain with guideline-adherent care, and 2 studies reported no difference in patient-reported pain with guideline-adherent care. 3 studies reported that patients who received guideline-adherent care received fewer treatments during the therapeutic process. Clinical bottom line. We found moderate evidence to support adherence to clinical practice guidelines to improve pain and disability ratings in patients with nonspecific low back pain. There is variability across studies in the rates of guideline adherence, as well as in the guideline specifics and methods to evaluate adherence. When treating patients with low back pain, clinicians should consider educating patients to stay active with normal daily activities, as well as receive active treatments, e.g. neuromuscular reeducation, self-care training, and group therapy, and exercises. Clinicians should also consider limiting passive treatments such as electrical stimulation and bed rest because of the insufficient evidence available to support their value in improving pain and disability in patients with nonspecific low back pain. Strength of the recommendation. Grade B evidence suggests that adherence to clinical practice guidelines is moderately effective in reducing pain and disability patients with low back pain. Search strategy. Terms used to guide search strategy. P. Patient. Adults with nonspecific low back pain. I. Intervention. Adherence to clinical practice guidelines for treatment of nonspecific low back pain. C. Comparison. Any treatment or treatment strategy that is not a clinical practice guideline. O. Outcome. Pain and disability ratings. Sources of evidence searched. PubMed, CINAHL, Cochrane, Ovid. Related article searches for relevant articles. Hand searches of reference lists of relevant articles. Inclusion and exclusion criteria. Inclusion. Studies investigating adherence to clinical practice guidelines for nonspecific low back pain, on disability, and pain. Studies that were prospective or retrospective in design. Studies of Level 3 evidence or better. Limited to English language. Limited to last 10 years, 2005 to 2014. Exclusion. Studies not investigating or measuring guideline adherence. Studies investigating guidelines for post-surgical care. Studies investigating guidelines for low back pain relating to traumatic injury. Results of search. 4 studies met our inclusion criteria and were categorized as presented in Table 1 based on levels of evidence. Best evidence. Our search strategy identified a total of 4 studies that were categorized as the best available evidence and were included in the critically appraised topic. Our selection of studies was based on their level of evidence ratings of 3 or higher, inclusion of patients with nonspecific low back pain, and investigation of the efforts of adherence to clinical practice guidelines for low back pain on patient pain and disability outcomes. Implications for practice, education, and future research. The principal focus of this CAT was on the adherence to clinical practice guidelines for the treatment of nonspecific low back pain and its effects on patient pain and disability outcomes. While all studies addressed pain and disability outcomes, some of the studies also investigated function, healthcare utilization, and costs. To measure adherence, 3 different methods were used among the 4 studies. One study developed a set of process indicators to measure adherence. One study used a point system, and the other 2 studies classified CPT codes as either active or passive to indicate adherence. While overall adherence rates varied, ranging from 28% to 100%, the methods of measuring adherence were different. Similar results for outcomes were found. All 4 studies that investigated disability found that increased rates of adherence were related to decreased disability. However, only 2 of the 4 studies found that guideline adherence had a positive effect on reducing patient pain. Finally, the 3 studies that considered the impact of guideline adherence on healthcare utilization and cost found that care was most adherent resulted in fewer healthcare visits and decreased costs. One important finding from this CAT was that several different guidelines were used by the research teams, suggesting that there is not one research-specific guideline that clinicians follow for treating this important patient population. The clinical practice guidelines used by the studies in this CAT include the Dutch Physical and Manual Therapy Guidelines, the guidelines developed by the Rehabilitation Agency of Intermountain Healthcare, and the guidelines developed by the Workers' Compensation Board of British Columbia. While different advisory groups support these guidelines, there are similarities between them. For example, All three guidelines encourage active therapy or treatment, including therapeutic exercises and activities, patient education, and advice to stay active. These guidelines also discourage passive treatments such as ultrasound, electrical stimulation, hot or cold therapy, massage, and bed rest. Maintaining activity and decreasing passive treatments seems to align with other findings for other research studies. Staying active as compared to bed rest has been associated with reduced pain, better function, and fewer days missed from work. Further, there is a lack of high-quality, consistent evidence regarding the effectiveness of therapeutic ultrasound, electrical stimulation, thermotherapy, therapeutic massage, mechanical traction, and EMG biofeedback on outcomes for patients with low back pain. All four studies that investigate disability in this CAT found that guideline-adherent treatment positively affected disability ratings, suggesting that adhering to guidelines is beneficial in reducing disability for patients with low back pain and increasing effectiveness and efficiency of care. These findings are clinically meaningful because they suggest that by adhering to care guidelines, patients perceive improvements in their ability to complete daily activities than if the care does not adhere to guidelines. It is also important to note that disability was measured with 3 different patient-rated outcomes measures: the Quebec Back Pain and Disability Scale, the Roland Morris Disability Questionnaire, and the Oswestry Disability Index. These outcome measures vary in their structure and content and capture a broad sense of disability related to back pain, and it is meaningful finding that patients saw improvement in all these areas of disability when guidelines were followed. The most troubling issues that patients with low back pain deal with is, in fact, pain. Therefore, better understanding the impact of guideline adherence on the presence of pain is essential. Only 2 studies found that guideline-adherent treatment had a positive effect on reducing perceived pain. The difference in findings could be due to the variance in rates of adherence and the methods in which adherence was calculated between the studies. Fritz et al., the 2 studies that found a positive impact on pain ratings, had very strict guidelines for adherent care. However, the strict guidelines may explain why a relatively low percentage of patients were adherent. In contrast, Rutten et al. Investigated all steps of the treatment process, including referrals, patient profile, history taking, evaluation, and treatment to determine if clinicians were adhering to guidelines. Adherence was only at 55% for the treatment step of the care process, which indicates that other steps in the process, such as patient profile and history taking, were adhered to more than the actual treatment recommendations. Less adherence to treatment may be one reason for the lack of impact on patient pain found in their study. Overall, differences in adherence to the actual treatment guideline may explain the inconsistent findings for pain reported across studies. Evidence from this CAT suggests that adherence to clinical practice guidelines is effective in decreasing disability in patients with low back pain in an efficient and cost-effective manner. Due to the complex nature of low back pain, treatment can be a lengthy and challenging process. Clinicians should focus on patient education and active treatments and limit passive treatment such as bed rest, hot and cold packs, and electrical stimulation. In addition, Rutten et al. Found that adherence to particular steps in the therapeutic process led to better patient outcomes. For example, higher adherence to the analysis and evaluation steps of the care process related to fewer limitations in function, and higher adherence to the treatment plan ultimately resulted in lower utilization of care. Further, 3 studies did investigate the difference in number of treatment sessions delivered for those who did and did not receive guideline adherent care, and all 3 studies found that patients with adherent care received fewer treatment sessions. Healthcare utilization outcomes are important considerations for both patients and clinicians. Unnecessary time loss, appointments, treatments, and, subsequently, healthcare costs may be avoided through adoption of clinical practice guidelines. Large observational research studies are needed to better understand the utilization of clinical practice guidelines for patients with low back pain. In addition, quality improvement work that assists clinicians in actually implementing clinical practice guidelines may enhance the treatment for low back pain patients, potentially improving patient outcomes. While the studies in this CAT provide some evidence to suggest that adhering to clinical practice guidelines decrease pain and lessens patient disability, more outcomes research regarding clinical practice guidelines is needed to provide greater confidence in these recommendations. Future research should use consistent methodologies for defining, evaluating adherence because the variability methods may impact interpretation of findings. Additionally, future research should target and compare acute and chronic low back pain to determine if duration of symptoms impacts response to guideline adherent care. Further, several different clinical practice guidelines for the treatment of low back pain were used, so a consensus on the actual guideline that produces the best patient outcomes is unknown. More clinical research that evaluates patient outcomes following different, accepted guidelines is needed to determine their true effectiveness. This CAT should be revisited in 2 years or when new research becomes available to see if the clinical bottom line for this clinical question has changed. Alright, that's the end of that article. Sorry once again for my very loud neighbors. I hope you guys really enjoyed hearing me read that article. You guys have a nice night.